without further ado, please join me in welcoming Dr. Rowland. Thank you, Linda, for that warm and gracious invitation and to be here, among other things, but also that introduction. So it really is a delight to be able to come back and see the growth that's occurred, the Bridges program that has sprung up and spanned, using that metaphor wisely, across many, many areas within the Cancer Center and across the province and increasingly a model for Canada. So I'm going to make my apology up front. I'm actually a native New Yorker. And even though I've been living in Washington, D.C. for 20 years now, which is, those of you who know your geography, is south of the Mason-Dixon line, don't expect that southern drawl or anything slow or crawling in here. When I have an opportunity to come and speak to an audience like this, what I really want to do is share as much information as I can about what I know about this burgeoning area of cancer survivorship research. So my advice to you is to take a deep breath, buckle up, and come along for the ride with me. So what I'm going to try and do in the amount of time I have this afternoon is a couple of things. I want to talk a little bit about why are we really interested in cancer survivorship? Where is this coming from? Why the focus there? What are some of the lessons that we've learned so far from the really, literally thousands of survivors who've spoken to us, told us about their experience? And what are the implications of what we've learned in that process for how we're going to deliver care and for the future of research? So we're going to try and do all of that in just this 50-minute time block, and I'm counting on Linda to, flash signals at me when I'm going to be running up against my time. So to the first question, why the interest in cancer survivorship? To me, the simplest answer to that is it's the sheer numbers in here. 28.8 million individuals with a cancer history worldwide, and that has to be a massive underestimate because it's only coming from 27 different sites. It's what we call limited duration prevalence. In other words, this is how many survivors are alive who were diagnosed within the last 5 years. We know that with increasing length of survivors, there are many, many more survivors. Even in Canada, the prevalence figures only go to 10-year prevalence. Again, an underestimation of the actual numbers you have here in Canada. 14.5 in the United States. Here we have complete prevalence. Actually, our tumor registry system, the first of which was in Connecticut, was founded in 1930s. Most of the rest came on board in the 70s, but we now have, with mathematical modeling, the capacity to do complete prevalence. In other words, capturing all of those individuals in the United States who have a cancer history. It's a reportable disease. Everybody ends up in a registry, so we can actually come up with these figures, and that's what they look like. And what's important to know about this, here in Canada, here's the disposition of the different tumor types. What's interesting to me when I went online and pulled these off, slightly different pattern in the United States. We have actually more breast cancer survivors than prostate cancer survivors, so different population here. But those top three, prostate, breast, colorectal, for all cancers combined, the largest prevalent groups in here, and the others look pretty similar. But most importantly is the pattern we've seen over time. So in the United States, we often think about starting this time log in 1971 when Nixon signed what was called the National Cancer Act and declared what soon became called the War on Cancer. In 1971, there were about 3 million cancer survivors in the United States. As I said today, it's 14.5 million. And there'll be a 31% increase in just the next 10 years, up to 19 million by 2024. That's a fast growth. And what's important to note, if you look at this, if I can get this to work correctly, is the fact that, I'm not going to mess with this because I don't want it to shut down again, is the fact that most of these individuals are actually living long-term following their cancer diagnosis. So they are 5, 10, 15, 20-year survivors. And in fact, in these figures, 15% of those alive were diagnosed 20 or more years ago. So people are now have the capacity to live a lifetime, potentially, after cancer diagnosis, particularly if they were younger when they were diagnosed. The final important point I want to make about this slide is it tells us how many people are out there, and it's survivors in what we call the advocacy definition. So you time of diagnosis for the rest of your life, you fall into that rubric. So prevalence figures is anybody who's had a cancer history. What it does not tell you is the health status of those individuals. We have no idea whether these people are in the middle of treatment, if they're post-treatment doing fine, no symptoms, they're struggling post-treatment, they've had a we can't even pick up recurrence in here. We have a way of estimating how many people within the first year of diagnosis and estimating approximately how many people are a year away from death. That's it. That's a huge gap area for us. I suspect it exists also in Canada, although I think with a national health system, you may actually have access to data that allow you to be more descriptive than we can currently be in the United States. From a research perspective, we need to fill in that gap, because if we're going to think about our cancer survivorship efforts, we need to show that they're actually making a difference. There's a document in the United States that's called Healthy People 2020. It's the objectives nationally for all different kinds of health conditions. And under the cancer rubric, so lots of things that we're supposed to meet, diagnosis, screening, recommendations, et cetera. But under cancer, there are two that are important. One is to increase the proportion of cancer survivors who are living 5 years or longer after cancer to 72.8%. Well, right now it's sitting at 68%. So of those diagnosed, 68% can expect to be alive in 5 years. Slightly lower figure I saw in Canada. I think it's closer to 64%. The second indicator that's in there, which I wasn't aware of until I went out and read this document recently, is there an expectation that we're going to increase the mental and physical health-related quality of life of cancer survivors. That's a great goal. We have no way of measuring it. So there's a research challenge for us, just to say, if we're really going to show our programs and services and what we're doing, we have to be able to develop the research design to capture the information to say we're actually making a difference at all. And the final piece in here is we think about early detection, better treatments, better supportive care. The big driver in the next decade or so is going to be the aging of the population. Those of us who are baby boomers coming through the pipeline here, I think of that image, the pig and the python. You know, python swallows pig, goes through python. Well, it's going to be like that. We have this huge bolus of people who are going to be older. Cancer is a disease associated with aging. We're going to see huge increase in older adults. And I make a point of that, and I'll come back to it a little later, is we have very little data on our aging population who happens to have a cancer history. And in the United States, our entire clinical trial system is almost predicated and excluding them from trial delivery, because if they have a competing condition, a medical condition, we often say they're not eligible for our trials. Well, that's a problem, because if the people who are being diagnosed come in with medical conditions, we need the science base to show us how to treat them. So we have Houston, we have a problem on this, and it is, again, another challenge area for us. So if you think overall what some of the big changes are, increasing numbers of people are going to survive long-term following their diagnosis, which is why the advocacy community said you have to think about survivorship from day one. We can't wait till you're 5 years disease-free later to make decisions about your quality of life or your exposure to toxic therapies. It has to be a dialogue that occurs from day one. We know that treatments are often very complex, so trying to fit all the pieces together, what are the risk factors, sequelae that are going to be in here, who are the players. We know that most people receive their care actually in the community. They may come into a specialty center, but more often than not, certainly in the United States, an estimated 80% are actually treated in communities. 20 to 15% are maybe in our premier big comprehensive cancer centers. We know that for many individuals, cancer can become chronic, maybe not the disease itself, but the sequelae of the disease or some combination in there. And there is an expectation, a growing expectation, because we're doing this all on an outpatient basis, that patients are going to be very engaged in their own care, and or their family members are going to be engaged in this care. So it makes the dynamic of how we're working with these populations different over time. So we've probably all seen this continuum. We often think of the cancer control continuum as spanning prevention right to end of life. We're happy to say that survivorship now has its own home on the cancer control continuum. But many of us would argue, as we've listened to survivors, that what's actually happened, and we've learned from our survivor population, that we've now bent this curve. This is not a linear pathway when we think of cancer survivors, but rather they enter into this, we treat them, and then we're back in the prevention and screening and treatment and prevention and screening and treatment until the individual dies, perhaps of their cancer, but in many cases perhaps something else. So it's, again, a different model, but it means if you're really fascinated by prevention, you can do that in a survivor population. You do not have to necessarily restrict yourself to healthy individuals. So it's opened the door to the entire cancer control continuum of research. So now I'm going to shift gears a little bit and talk about, so what have we learned from all of this research? And every time you see lesson learned, you have to think thousands of survivors who've been willing to sit down, do our paper and pencil test, interview with us, share with us their experience of what it's like to live through and beyond disease and treatment. So I'm always mindful that this is always about the survivor's voice in here. And one of the things we learned right away is language is important. And this is a picture actually of the 23 individuals who founded what later became the National Coalition for Cancer Survivorship, a group that convened in Albuquerque, New Mexico in 1986 and gathered together and said, well, you know, we're having a problem with how a survivor is defined in the United States. At that time, 1986, the definition of survivor was someone who had remained disease-free for 5 years. And they said, well, you know, that's not okay. The reason it's not okay is because, as I mentioned before, you need to be making treatment decisions for the rest of your life. You need to be thinking about what's going to happen. And so they said, we're going to adopt and promote this new definition. And I want to make it very clear that they had no intention of labeling people. They didn't expect people to say, I'm a survivor, I'm a survivor. That was really not their intent. What they really wanted to do is two things: a message of hope. You're diagnosed, but there is life after cancer, and rich and rewarding life to be had, and we're going to work together to get that. But the second and important one was that there would be a dialogue at the time of diagnosis. So really what they wanted to do was change the culture of care. And there's been lots of debate over time because people have thought, well, this is a label, and is that lots of survivors told us, I don't think of myself that way. To me, a survivor is someone who was in the Holocaust or got out of the Twin Towers on 9/11. I don't think of myself that way. Or you don't call someone who's had a heart attack survivor. So I don't want to frame it that way. And we have a whole nother group of individuals who say, I'm not just surviving this disease, I'm thriving. I'm going above and beyond, so the label doesn't fit me either. But again, wasn't intent as a label, was intent to change practice. And I would argue, I think, both north and south of our borders, that we have actually achieved that. We have survivorship, we use that language. I will tell you, it's very North American centric. If you go to Europe, and certainly if you go to the Middle East or the Far East or other cultures, sub-Saharan Africa, this is not in their lexicon. Partly it's if you're in a third world or a low-income country, it may not be in your lexicon because there may be a tipping point where you have to have the majority of people diagnosed can expect to be alive in 5 years. If you're still struggling to actually enable someone to survive their illness, then survivorship may not be on your radar screen or in your health policy payment plans in here or where your government's going to focus. But arguably, once you head over that mark, then you have to be thinking about it because the majority of people are going to be exposed, and we have to be thinking about their life after cancer. A corollary to that, actually, is that what we've learned in the United States, and again, you probably felt here to some extent, advocacy is critical. I would not be here today if it weren't for advocacy, because it's actually the advocacy community that helped establish the Office of Cancer Survivorship at the National Cancer Institute. It was actually a white paper that came out of the National Coalition for Cancer Survivorship that was presented in 1995 to the then director of the Cancer Institute, Richard Klausner. The person who presented it was Ellen Stovall, who was formerly president, chief executive officer for the coalition. And it was a lot of us, scientists and clinicians, had gotten together and written up this booklet, Imperatives for Quality Care, that said we have no information. We don't know what happens to people after treatment. We need the science in here. It's terrific that you're funding research that allows us to effectively treat and cure more people, or allow people to live with long-term with these diseases, but we don't know what their life is like afterwards. So the office was basically created to address that, to define and support and direct research that would answer the question of what are the long-term and late consequences and how are we going to either prevent them from occurring or mitigate their impact, to train researchers and clinicians to do the research needed for this and to deliver that care, and then to disseminate that information. So being here today helps me fulfill one of the office's roles, which is disseminating that information, getting what we know out to groups that really need to be able to use that information to the best ability. Okay. And have we been effective over time? This is actually a nice little study that Electra Pasquette and colleagues at Ohio State ran to say what's changed over time. The demarcation there is 1996 when the office is established. Have we seen the growth of research? And the answer is yes. So many more psychosocial studies, very slow or incremental progress on more medical outcomes in here, which is really the late effects studies or prevention and early detection, lagging a little behind. But I think, again, suggesting that these are areas for investment, growth in areas for us to be considering. So what are we funding in the NCI? Just give you a sense of what it looks like, again, south of the border. And here, what we had done for a while, starting in 2000 up to 2006, every year we would look NIH-wide. So the National Cancer Institute sits within the National Institutes of Health. National Institutes of Health encompasses 27 institutes and centers. The structure is often in disease-focused parts. So there's the National Health, Heart, Lung, and Blood. There is the kidney disease and related disorders. There's mental health. I mean, we kind of do body part science in here, but what we realized, there's the National Institute on Aging and Nursing Research. We realized that NCI was never going to be the entire holder for research in the survivorship domain because it's now cross-cutting science. So when we do our portfolio analysis to look at survivorship science, and we narrowly define survivorship as studies that are looking at individuals either starting during treatment, but at a minimum following people 6 months post-treatment, up over time, any length of time, but it does not include studies of people who are in active treatment or with recurrent advancing disease. So if you think of the survivor portfolio, it would be bigger. We segment it just strictly for survivorship science. So that's kind of the way we looked at it, in part because that was the mandate of the office, is to foster growth in that area. So if you look, we did this for FY12. So our funding year ends in September. It's kind of like we are with the Jewish calendar. Financing here. We are in now fiscal year 15, even though it's not 15 yet. We are in fiscal year 15. We don't have any budget. I will tell you, we're in a continuing resolution. We'll see what Congress does this week to renew that. We hope we're going to have money and that they don't close us down again, which is what they did last year. But you can see what our grant portfolio looks like. And when you look at the research grants, so that's the blue and the red, you can see roughly a 50-50 split between grants that are looking for descriptive analytic studies, what are the problems that people are experiencing, and then interventions to address those. We've had a growing portfolio over time, which is interesting to me, of training grants. So these greens, these are individuals who are coming in for either individual training or these are training programs that are being mounted addressing this topic. And then we have some conference grants in this area. For example, we've hosted for many years a childhood long-term and late effects, the Niagara conference that's been for pediatric cancers, one of the seminal conferences looking at long-term and late effects in that population. So if we look more specifically, it's breast. We need to move out of that particular site, but they are a fabulous population because it's a paradigm for research. And you think of breast cancer survivors as representing the entire developmental continuum. I've seen adolescents right up to centenarians who have developed breast cancer. We use all the treatment modalities. It's a body part of importance to both to women themselves, the public. In here, it has genetic risk indicators. So if you're thinking as a model, and women have been very willing to engage with us in studying this disease, and big advocates, gone downtown, went to Congress, argued that we ought to be funding this is an epidemic, that we need to change the outcomes for women, and garnered money that actually was funneled through, surprisingly to many of us, the Department of Defense. So for a period of time, the U.S. Department of Defense was one of the biggest funders of breast cancer research in the country. Go figure. They now study prostate cancer, which has expanded their horizons, and many other kinds of diseases. But it started with women's advocacy in this arena. So not surprisingly, we have a lot of research on breast cancer. But again, if we're looking for gap areas, we need more science in all of the other cancers represented. And to me, shockingly, when you think of that pie chart again, big population groups, colorectal cancer survivors is a large population. We have very little data in that population, which is sort of stunning because it's a common cancer, but among both men and women, and yet we don't have a lot of data on adaptation, the physical problems, the psychosocial sequelae of that in that particular population. So again, these are, when we do these analyses, it helps us think what are the directions we need to be going. And then these are some for just the physiologic grants. So we sort these by psychological grants, physiologic grants, grants that combine both, health behaviors, so we can cut the data in a variety of different ways to ask different questions. And here you can see some of the common sequelae that have been a focus of attention here. Fatigue, one of the big ones up at the top, sleep, nervous or recurrence, etc. So it gives you an idea of the kind of sequelae that have been focused on here, and also what's not in there. So if you have your particular toxicity that is of interest to you, you say, is it being studied or not? And then it can inform you as to whether or not that's a gap area. So when we step back and we look at all of this, one of the things that we've also learned is the next lesson from our survivors, and that is specifically that post-treatment survivorship is not only unique, but it has the capacity to literally affect every aspect of an individual's functioning. We know from physical sequelae, psychological, social, economic, existential. Some of these effects are acute and go away once exposure stops. So I think of nausea, vomiting, hair loss, anemias, mucositis, kind of acute treatment-related effects. But what we've learned over time is the persistence of many of these problems: fatigue, sexual dysfunction, depression, pain syndromes, bowel and bladder dysfunction, eating disorders, sleep problems that persist over time that we used to dismiss. Having been in this field for a very long time, we used to tell survivors, they come back for their 3-month follow-up visit or 6-month follow-up visit and say, it'll resolve over time, don't worry about it. And they would drag back into our offices at 8 months, still with these, I can't remember anything. And we say, well, it's all in your head. Well, yes, it is, because chemotherapy is changing brain structures and it is changing cognitive processes. It is not a figment in here. These are very real problems that are being experienced. And then, of course, the third type of side effect are the late occurring, 6 or more months after, often years after treatment. We worry most about recurrent or new cancers. So in the United States, our current estimate is of those newly diagnosed this year, approximately 16% will have had a prior cancer. So we're second malignancy, 16%, this will be a second, third, fourth, fifth malignancy for them. Totally understudied. We have no data really on what is it like to have multiple cancers. Certainly a challenge for our clinicians, because how are we going to treat somebody who's had all of this prior treatment exposure? How are we going to coordinate that care? What are the outcomes? Is one of my friends who was a survivor of multiple cancers once said, your first diagnosis, it's fear of the unknown, what's going to happen. When you're re-diagnosed, it's fear of the known. So it changes the context, it changes the concerns, and we know, again, very little about this population. And growing, as we've seen more and more survivors, the one consequence, and when you think about it as a high-end problem, it's terrific that we now have more and more people who are going to survive long-term. But now they're developing the things that were on the small print in your consent form. You may develop this. The putative risk factors. We know radiation can cause cancer, but we're not expecting you to develop it. Except now you're living 20 years, and now you're going to experience the sequelae because you've had enough time to develop that. So we're seeing more of these secondary effects. Some of them treatment-related. Some of them maybe because it's shared genes, shared behaviors, shared exposures, or simply getting older. So we have all of these concerns now that are growing focus of attention, and that's these competing morbidities and how we're going to manage those. And we certainly know that quality of life, when we do big studies comparing individuals who have a cancer history with those who don't, and these are data from the National Health Interview Survey. So for those of you not familiar with that, it's an annual in-person population-based survey, the data from which is used, at least in the U.S., as a source of information on the health of non-institutionalized U.S. citizens. And we use that as a tracking device, basically, to see how well we are doing with the health of the nation. So these data allow us, we can pool years over time. We can select out people who endorse a cancer history and then look at their counterparts who don't have that. And we can see that they're saying that their health is not as good overall. They are also telling us that they have many more comorbid conditions than people who don't have a cancer history in here. And they're having more trouble with their activities of daily living, their ability to do things, instrumental activities daily, whether they can bathe or cook for or dress themselves or go out and shop or do a job or drive a car, etc. in here, and needing help with that. So again, when we think, if I go back to my original comment about is there a source, we could use the National Health Interview Survey, although the trouble with this database, and we're going to look at emotional and physical outcomes because it is a national base, but these are heavily censored because the people have to be well enough to get into the sample in here. So you have a very healthy, give you an idea of the healthiest people, how the best group is doing out here, really tells you nothing about people who aren't access to or who, for whatever reason, decided not to participate. So it's not really population-based in the way we would want to acquire these data. But we have used some of this data, you'll see a little later, looking at some of the things that our survivors do that are different, or ways that they are behaving that's different than people who don't carry that history. I wanted to add this slide in here because, so often we look at these data and say, as do individuals who are diagnosed, say, well, I'm going to die of this disease. Well, actually, the majority of some cancers are not going to be the cause of death for those who are diagnosed. Certainly, there's probably, I actually haven't seen if somebody has a reference for it. I'd love to see it, or I may have to go to my SEER colleagues to say, project it for me. The correlation between age at diagnosis and likelihood of dying of another your original cancer or another cancer, I'm going to surmise it's pretty highly correlated with age. The younger you are, the higher the risk that you'll die of a cancer, as opposed to older. So if you were, have breast cancer, and when you're 20, you're probably at much higher risk of dying of breast cancer than a woman who's 75 and dying of and diagnosed with breast cancer. So 75-year-old is going to die of something else. But we have to keep that on our mind for a couple of reasons. One is the messaging that we give to our survivors about, are they likely going to die of this? For many of them, probably not. But it's an important health message because there are other potentially preventable conditions or conditions where we can move in that we should be addressing. So if you're going to be at much more risk of cardiovascular disease, I want to be sure you're getting your cancer surveillance, but I want to be working on your heart disease risk because that's what's going to take you out. So I think our survivor population, by and large, doesn't hear that and doesn't necessarily appreciate that. And that is something for us to be considering. So when you think of care and practice in here, can we identify people who are at high risk for some of these adverse outcomes? And certainly we have a cancer and aging research group led by Artie Huria from the City of Hope that's trying to develop models for a high-risk identification. Here they use geriatric assessment, and there are just some simple measures in here that are pretty solid predictors of the older population who, when exposed to chemotherapy, are going to do poorly. Things that you could do rapidly in the clinic, and they are big proponents of some kind of quick geriatric screening to tell us who's at risk for patients who are coming into the clinic. Very, very provocative kind of messaging out here. Then the second, of course, is what are these mechanisms of risk? So why would some people be at more risk? We certainly know there are gene-gene interactions, gene-radiation interactions in here that put subsets of populations at risk that we need to be exploring more because we now have a list of some of the toxicities, but not necessarily data on who's at most risk. So if you're at risk for fatigue, who are those subset of people? Because if you look at a lot of the risk modeling, it's 20 to 30% of these, 20 to 30% of women with breast cancer remain fatigued over time. Who are they and why? And what's the mechanism in here? And of course, there may be something you bring to the disease here. Colleagues Tim Allis from Memorial Sloan Kettering looking at cognitive outcomes and suggesting that if you had the ApoE allele, which we know is associated with Alzheimer's, are you at more risk for chemotherapy? In that case, would you alter the chemotherapy regimen? Or are you going to be doing something different here? This, to me, at some level, is also what precision medicine is about. It's not just matching your gene array to a specific chemotherapy, but it's the rest of the matching. So your genes with other physiologic outcomes or your psychosocial needs. My favorite example du jour is a woman that I met about a year ago now, in her early 40s. She was a high-powered lawyer who happened to have been blind from birth. She came to a cancer group that I was participating in, and she told the story of her diagnosis. She had gone to her oncologist when she was originally diagnosed, who laid out for her and said, this is a recommended treatment for you, and because of your tumor markers and the stage of your disease, I'm going to recommend that you do chemotherapy with this drug called Taxol. Well, and this woman said, I've done my homework, and I understand there's a very high risk with that particular drug of developing peripheral neuropathies. And she paused and she said, I read Braille, and I have a seeing eye dog, and I need to know where my dog is and where my feet are on the ground. I can't afford to lose that capacity. Well, they took that drug out of her protocol. That, to me, is precision medicine in its full dynamic in here. That would have been life-altering for her to be exposed to that particular drug if we can get just as efficacious a cure. And even if it's slightly less, her quality of life alone and her ability to fashion is probably going to put her in a better position than had we compromised that. So I think this is a whole new era that we're in now. And we have the opportunity to keep pushing and saying, what are some also the behavioral psychosocial risk factors in here, along with your genome, your metabolome, your proteome picture in here when we go to put together care going forward. And then obviously the implications, that's one of them in here. And also for follow-up, if we know you're at risk for a late sequelae, we're going to monitor you a little differently than somebody who is at a low risk for developing some of these problems. So we've done some of the negative kinds of things in here. The reality is what survivors tell us, and I think anybody in this room who is on the front lines and sees patients in and out will share with me the same feeling I have, the remarkable resilience of the people with whom we have the privilege of working, to go through often very arduous, lengthy, toxic therapies and come out the other side. Very remarkable. In fact, the majority of people actually do pretty well. Could do some hand-holding support. It's a smaller subset, though, who are very high risk and need targeted assistance. And that's where I think programs like Barry's and Linda's working on, and Janine, extraordinary programs where you can identify some of these people up front and really get in and make a difference that's going to have survival outcomes, not just morbidity outcomes. I'm guessing survival outcome difference here. And the thing about it is we already know how to do some of these interventions, in particular for anxiety and depression, but we're not delivering on them. So I think one of the challenges we have, and this is a nice meta-analysis of some of these studies showing that, again, a variety of different kinds of interventions, we can significantly alter distress patterns, anxiety, depression. And the bottom one I like in particular because here they pulled out those studies where they took, in particular, people already at high risk. In other words, a lot of our intervention studies, we'll take all comers. Anybody coming in the door, we're going to measure you, but we're actually going to take care of everybody. The problem with that from a research design is you've just knocked off some of your significant differences in here because you have put in people who are already going to do well anyway. So if you really want to maximize the what looks like your efficacy of your study, you're going to increase the number of people who are struggling with it because those are the people who are going to benefit the most. Kind of an obvious thing, but our IRBs actually make us go the other direction. So it's an interesting tension in the research world is delivering on what we already know. And I think if you would ask me, I'd say that's one of the big themes that we're hearing. We already know how to do a lot of this, and we're not doing it. We keep going back and finding it again and again and again and again, instead of saying, we know this, we know the risk factors for some of these things, now we need to intervene, and we need to do this systematically and figure out how to deliver that care. And in the United States, again, we had another Institute of Medicine report saying just that we had really obliged to screen, and we need to then link people with the right resources in the community. And again, I think that's something that Bridges does, that Barry and his group have done brilliantly, is to find out what's in the community where we can send people. If we can't deliver it right here in our backyard, or if somebody is remote, positioned in a place where they don't have individuals there, can you do this on tape? Can you do some of these wonderful programs and send them out into the community and actually make a difference? One key point I'll make about this IOM report that's often forgotten, to me, is one of the most important pieces, and that's that little box on the bottom, and that there is follow-up at the end. So often what happens in here, patient comes in, patient's depressed, you may prescribe a SSRI or send them to a counselor, make a referral, and tick it off in your box, and it's done. And actually, some of the indicators here, you would be done because you've just met your quality assurance thing. Yes, I screened for it. Yes, I made a recommendation. Yes, I charted it. The problem is you don't know if you fixed the problem. The biggest issue in here is, did you come back when that patient came back in your office and said, how's that depression? How are you feeling? How are things at home? And if they aren't good, stepping in and doing the right thing. Because we know so many of our patients don't take the meds, or think you've just told them you have cancer, now you're crazy, or their family says you don't need that, or they feel inadequate, that their coping is poor and there's something wrong with them, so they feel badly about it, or they took the medication and it gave them terrible side effects and they abandoned it, whatever. If we don't ask, we don't know. And we don't know which interventions then are efficacious or whether we're reaching the population. So I don't want to just beat this into the ground, but I think it's the place where we fail. And it is the place in our quality indicators that we don't have a measurement device. And I think we need that. Did it work? Did you come back and say, did you make a difference? We've seen this, of course, also in the, when I think of, again, Barry's wonderful movement for distress as the 6th vital sign. With the 5th vital sign, pain, we do a great job of assessing pain, but we also don't always go back and say, are we making a difference? We're assessing it, we're prescribing some things, but can we show that we're making a difference in here? Not just in patient satisfaction either. I'm talking about morbidity outcomes, healthcare utilization, functional ability in here, and possibly long-term in actual survival benefits. So I think we have work to do here. The Institute of Medicine has put it out here. They've said, this is where we need to be going. So at least in the States, we have a document we can go back to and say, this is a nationally relevant document that we can turn to and say, we need to be doing this. So again, that question of efficiently identify, great work being done here, what types of services and programs. I think what we get is a lot of resistance in the community. When I think of community practitioners, I'm not going to ask about it, because what happens if this person says, I'm depressed or distressed, and I don't have a social worker in my little practice, or I don't have a mental health person affiliated? Nobody's going to ask. Having worked for a long time in sexual rehabilitation arena, I know in the clinic nobody was going to ask if they didn't know Julie was there, because Julie would come down with the Riplens and the Astroglide in her pockets, and she'd be willing to have these conversations that we're not willing to have, because in the United States, the two things we really don't talk about are sex and death. We don't have sex, whatever, and we're not going to talk about death and dying. So you need somebody on that team who's willing to have those very, very important conversations. And it's the same thing here. If you haven't figured out who's in your backyard, you're not likely to ask about it. So one of the challenges that we do have is encouraging clinicians or their staff and teams to say, let's find out who you're going to refer to. If it's, you need smoking cessation, you need a family member's in distress, you need some referral mechanism in here, because if you're going to bring it up, you do have a responsibility to act on, but you don't have to do it yourself. And I think that's the key in here. And then, of course, that question is, if we intervene, does it make a difference? And I think all of us would say it must make a difference, but the empiricist in me says, show me the data.
Oh,
Somebody's unmuted your phone at one of the sites. And now they've walked away. So a fourth lesson that we've learned from, again, many survivors in here is cancer may provide that teachable moment, in particular when we think about health and lifestyle in here. And you could say, okay, so what's the thinking behind that? And I think first and foremost, you have a growing population of survivors, and they're living longer, so this is becoming more of an issue. They're older, maybe coming in older, and they have some health issues, but they're also aging with their disease in here. And we know already from the data we've seen, they're at risk for more comorbid conditions, either because they came in with one and we've exacerbated for them, or we've now induced some of these conditions in here. Many of our survivors gain weight, although we certainly see the opposite in here, and they've stopped exercising because they're afraid to go back to the gym and don't know what they can do. And importantly, they're asking for advice. They're coming in and saying, Doc, what should I do? Or asking their nurse, or asking their fellow, or asking one of us to say, is there something I can engage in here? Really pressing us to step up to this and provide some answers for them. And I think that's really important. And I have to, sometimes I look at this and I listen to the whole survivor population, and they're asking, oh my gosh, they're asking for primary prevention. We don't do that in the United States. You maybe do it in Canada, but we don't do it in the United States. We certainly don't pay for it, except when you're up to 14. So we do a great job with kids. All that early immunization and well baby and all that, and then it stops at about 14 unless you're on teams, and then you have to have physician clearance to go play on your teams, check out your helmets to make sure they're not going to kill you later, and then we just kind of leave you on your own until you come back with your first comorbid illness. It's a little better now because we have the Affordable Care Act, which allows people to be covered, but we used to have this big uncovered population also. So you got to be an adolescent, you're no longer on your parents' insurance, and you don't think you need insurance. So you don't come back into the system. Women stay attached a little more simply because they are seeing perhaps a gynecologist, or they're having babies and they're in some kind of thing. And our gynecologists in the U.S. consider themselves primary care providers. But I say all of this because our survivors are saying we have to change that. We want to know about prevention and talk to us about our health behaviors. And we know that if we intervene, we can help promote better outcomes for these individuals. So there's that teachable moment, that opportunity to intervene. And then the question is, so what are these behaviors and how bad is it out there? And these are actually data. The NCI also produces something called Cancer Trends Progress Report. We cull data from a variety of different sources. The National Health Interview Survey that I talked about before, looking at prevention behaviors, whether people are getting the vaccines, if they're physically active, what their diet looks like, if they're doing regular screenings as recommended, et cetera. This happens to be data for smoking. And if you look at this carefully, it's terrifying, because what it tells you is that our young survivors, our youngest survivors, are telling us that about 40% plus of them are current smokers. Whoa, what's wrong with that picture? Our survivors are telling us they're smokers at a rate far higher than their peers. And older groups are no less than their peers, and you really want them to be a lot less than their peers. But it's almost like they're coming into us and we're thinking, well, I'm focused on the cancer, and I'm not going to pay attention to the fact that they're smoking up a storm out here, which is not going to be helpful for them. Oh, 5 minutes, I'm going to fly. We also know that they're not having these conversations about health behaviors with any of their providers here. They're doing a little better than the general public, which gets back to the point I was making earlier. We're not big on health promotion conversations in here. So the question now for us is, what is going to be this obesity? Don't know how bad it is here in Canada. It is bad in the U.S. Marching along here, what's that going to do? Can we leverage that moment? What kinds of things can we put in place when people are ready to hear health promotion messages in here? And here, what kind of interventions mechanistically work? We actually have a program announcement in this trying to say diet, weight, physical activity interventions, how might they be modulated, and how do they affect morbidity, mortality outcomes, trying to look at the mechanistic underpinnings in here. You've heard cancer disease of aging. That's not new, but again, it's compelling. We forget about the fact that most of our survivors are older adults. They're not young people. Even though a lot of our research is in the pediatric community, because that was a vanguard of our survivors, so we have a lot of data out of young survivors. We don't know what some of those patterns of long-term and late effects are. And an interesting new question here, one that I'm really provoked by, I think it's really intriguing, is, are we prematurely aging populations? And this data actually comes from our pediatric survivors. You may have seen this, Kevin Effinger and colleagues, New England Journal of Medicine, showing that as our young survivors now get into middle age, they look like old folks. 80% of them have serious comorbid conditions. We've cured them to chronicity. That's a problem because it's the canary in the mine shaft. Are we doing this for adults who are now living long enough? And the answer is probably yes. These are data from Lee Jones, formerly at Duke, now at Memorial Sloan Kettering, and he's looking at pulmonary function in breast cancer survivors. And here basically what he's seen is that these women after treatment, when they're, so the top red bar here is, those are women 50 years old, but their VO2 peak looks like women who are 70, their peers who are 70. And he's thinking that what's happening in here, this kind of very alarming data, is that what happens, they come in on the same thing, they get exposed, and they're dropped down by this big, 15 to 30% differential that does not bounce back after treatment. And the question is, can we mitigate that? Can we get them moving in some different way? Can we give them, some different kind of intervention? I mean, these are very provocative data, and we don't know what underpins it, but it's going to be interesting going forward. We also know that cancer is a family illness, again, neglected population. As you saw in the original definition, family members were included under the rubric of survivors, but we don't assess them, even though increasingly they're important to survivors' outcome and well-being. These are data from CANCOR's Cancer Care Outcomes Research Surveillance Consortium, where we looked at lung and colorectal cancer survivors, where many of these caregivers are telling us, I'm juggling multiple roles, I have kids, taking care of my loved one, I'm not in such great shape. So if you think of cancer patients as older, their caregivers may also be older and struggling with comorbid conditions. So again, neglected population, great place to do research. And one question is, can we intervene and not only improve the health of caregivers, but also their care recipients, these dyadic research. We're actually going to have a meeting later in the spring to try and figure out where is the state of the science there and where do we need to be going. Is it a teachable moment for families? Again, the CANCOR's data, we saw high concordance in smoking behaviors between patients and their survivors. Again, can you intervene on both sides? And then we worry a lot about economic well-being of our families. Even if you have health coverage, the cost of these diseases is huge. And then finally,
You got 10 minutes.
Okay. All right. Okay. Finally, and of course, we're very hung up about this. South of the border is our whole healthcare system here, because it's not only is it fragmented, it's broken. It's seriously broken. We have the newest IOM report says just that it's in crisis, and that we have to fix it. We need to do something about it. And that's where some of the survivorship research is headed in here, is what are going to be these models of care. And it's driven by several things. Again, our Institute of Medicine reports, the President's Cancer Panel report, all three of these within them said, because of all the things I've told you, the persistent and late effects of cancer, this difficulty of making the transition, what happens after treatment ends, that the survivor community says we need a plan. We need to know how this is going to work after treatment. We often have a plan during treatment, and then you get to the end, and it's good luck, goodbye, have a nice life, see you in 3. That just doesn't work, particularly if you're leaving with lots of toxicities and lots of questions, and you don't know what the game plan is. So the real request in here is to have a game plan. American Society of Clinical Oncology, it's COPE, which I'm sure there are Canadian participants to that, has some quality indicators in here. They do have an indicator for treatment summary. It was a treatment summary generated and given to the patient and somebody else. That's just a treatment summary. So a survivorship care plan is 2 parts. It's a treatment summary that then helps you populate a care plan, a follow-up care plan. Together, that's a survivorship care plan. So 2 parts. Treatment summary is not it. Treatment summary helps inform the population of the care plan. And the components of the care plan, the Institute of Medicine actually has 11 components, but basically they're in these 4 broad domains: surveillance of recurrence for a new cancer, whatever, assessment and referral for persistent problems in here, and evaluation for late effects and prevention of these, health promotion as part of that as possible, and then coordination of care. Who's going to do what, and who's going to collaborate with whom? State of the art, we're not doing such a hot job. Lots of support for this, great idea. Here, these are, top one is NHIS data. Again, we added a module to it to ask about care plans, et cetera. 58% of survivors said they were getting something. It's probably come back in 3 months. I think we would probably look at this and say, not a survivorship care plan. Talia Saltz and colleagues at Memorial Sloan Kettering have looked at this, and they went to our big comp centers, NCI designated centers, and said, what are you doing in breast and colorectal cancer here in particular? And you can see lots of support for it, but actually we're not really doing it, and forget all 11 IOM. And I would say if they got the sort of 4 broad areas, I would give them points for it instead of holding to the 11. And then these are data from our study called SPARKS, the survey of providers' attitudes regarding care of cancer survivors, a physician survey. We had 1,100 medical oncologists, 1,100 primary care docs to look at what they believe should be care. And you can see a lot of oncologists are saying that they are talking about survivorship care, but they are not really saying who's supposed to follow you, and very few of them were giving survivorship care plans out. On the other hand, oncologists who got training in this were doing a better job, and primary care physicians, importantly, so if you think of that cascade, what the handoff is going to be, that those who received some kind of survivorship care plan were felt better equipped to care for this growing population. So the questions here then are, what impact does this have? We need to say at multiple levels. Does it change patient behaviors, patient outcomes, patient interactions? Does it change how physicians interact with patients, with other physicians, how they deliver the care? Are they following guideline-based care? We can look at those kinds of things. What should it look like? Do we need a triage system? Does that work? What are the multiple models? Probably not one model's going to fit all. And then who should provide what to whom? I have one last complicated slide. This is also out of our SPARKS data, and part of me says, just go read the paper because this is so busy in here. But basically what we were trying to do is, we'd ask the primary care docs what you're doing and what the oncology docs think they're doing. And you can see there's total disconnect in here. The oncology docs for some of these things would say, let's say the first one, assessment of adverse psychological events. Well, the oncology docs, more than half of them, a little more than half of them are saying, well, I do that alone. Very few of them share it with the primary or the primary care doctor, not so much. And the primary care doctors are saying, yeah, we do this. So the disconnect in here, and basically the findings from this were that the oncologists didn't quite didn't feel that their primary care clinicians got it. And the primary care clinicians were saying, I can do this, but I'm anxious about it. I would like some more guidance on this. So can we do some kind of shared care? What are the educational
directives that we need out there? How do we communicate that? If we give back this nice document, a care document that helps primary care physicians know what is appropriate and not appropriate, which tests should you not be doing, and that we don't have our patients going to multiple providers. I think we see much more of that in the States because they can go to 6, 7 different physicians for their follow-up care, which makes no sense. Having raced all through this, I think this is an enormous time of opportunity. We have much more attention to outcomes of survivors. We have many more individuals who are coming into this field. I think more care. We have lots of technology that we're going to be able to use to put towards this. And I think importantly for us, and I can't underestimate this, we have an advocacy community. I don't know if you use it up here in Canada, but if you want things done, at least in the United States, if we want compelling testimony, you go to a survivor and you send them down to Congress because that's where the purse strings are. Or you send them up to your center director and say, we need to have this program in our center because it's critical to our well-being. Using them as allies, not coming to them last minute, engaging them in every piece of the care delivery and the research process, because that's going to mean that you not only have champions for what you're doing, but you know that what you're delivering is going to be meaningful. So with that, I'm going to stop and say, I think you're doing a fabulous job. We all have this great array of opportunities and challenges ahead of us that we can work collectively to resolve. So thank you.